Good morning, my dear students. Today we will see about normal puerperium. Puerperium means a period following childbirth during which the body tissue, especially the pelvic organs, revert back to the pre-pregnant stage, both anatomically and physiologically. It is also known as fourth trimester of pregnancy. But involution is the process whereby genital organs, especially the uterus, revert back to the approximately to the pre-pregnant stage. The puerperium is divided into three: immediate within 24 hours, early up to 7 days, and remote up to 6 weeks. Puerperia is a woman who is in the puerperal period is called as puerperia. It's mainly two types of changes: progressive and retrogressive changes. Progressive means coming forward and retrogressive means coming back. Only two progressive changes occur during puerperium are the breastfeeding and ovulation. All other changes comes under the retrogressive changes. Involution depends upon three processes: contraction of the muscle fibers, catabolism, and regeneration of uterine epithelium. Involution begins immediately after the delivery of the placenta. Contraction controls the bleeding from the area where placenta is separated. Total number of cells unchanged, but the size of the cells undergo catabolic changes. Increased estrogen and progesterone levels are responsible for massive uterine growth during pregnancy. Prenatal uterine growth results from both hyperplasia and hypertrophy. Postpartally, the decrease in secretion of these hormones causes autolysis, that means the self-destruction of the cells. Regeneration of uterine epithelium lining begins soon after birth, completed by 16th day, except the area of placental attachment. But the placental site heals by exfoliation, that is scaling of dead tissue. This leaves endometrial layer smooth and spongy. The scarring of uterine lining interferes with the implantation of future pregnancies. Healing of placental site occurs slowly and it requires nearly 6 weeks. Healing at the placental site occurs slowly and requires approximately 6 weeks. The rate of involution: for 24 hours there is no change, but from 2nd to 11th day fundus descends at the rate of ½ inch to 1.25 cm per day. By 11th day the uterus sinks behind the symphysis pubis and becomes a pelvic organ. By 2 weeks the uterus cannot be palpated by abdominal examination. The weight of uterus: immediately postpartum the weight of uterus is 1000 gram or 1 kg. 1 week later it becomes 500 gram. At the end of 2nd week it is 300 gram and soon thereafter 100 gram or less. At 6 weeks of postpartum it becomes 60 to 80 gram. Total number of muscle cells do not decrease. The individual cells decrease markedly in size. Autolysis of muscle fibers and ischemia of the uterus leads to protein autolysis occurs. The end product of autolyzed muscle, peptone and creatine, are excreted through the urine. Separation of the placental membrane involves the spongy layer. Deciduum basalis remains in the uterus. After pain: you might have heard about a term after pain. It is the pain which occurs in the arm after the delivery, almost same like a labor pain contractions. Primiparous, the after pain is more common in multiparous women than the primipara. Because of primipara, they have the tight abdominal muscles. Multiparas contract vigorously after the interval and they are most common for the after pain. When the infant suckles, oxytocin releases and uterine contraction occurs and therefore this leads to the after pain. Occasionally severe enough to require analgesics, otherwise it will be self-limiting. Usually become mild by the 3rd postpartum day. Lochia. Lochia is the vaginal discharge which comes out of the uterus for the first 15 days soon after delivery. Early in the puerperium, the slugging of decidual tissue leads to vaginal discharge of variable quantity. It consists of fatty epithelial cells, membranes, decidua, and the blood. Lochia rubra is the first one. For the first few days, that means 3 to 4 days after delivery, the blood sheds of fetal membrane, decidua, vernix gaseosa, lanigo, and meconium in lochia. Lochia is the serosa, more brownish in color. After 3 to 4 days, become progressively pale in color. Last one is Lochia alba, which is white in color. After 10th day, white or yellowish, or it is white in color. Lasted approximately 2 weeks after delivery. Significance Lochia. If it is odd, if it is offensive, it indicates infection. If it is scanty or excessive, both are indicative of infection. Persistence of Lochia rubra beyond the normal period signifies subinvolution or retained bits of conceptus. Duration. The duration of Lochia alba beyond 3 weeks suggests local genital lesion. Scanty means less than 2.5 cm stain on the pad. Light means 2.5 to 10 cm stain. Moderate 10 to 15 cm. Heavy means saturated pad in 1 hour. Excessive saturated pad in 15 minutes. Descent of the uterine fundus. Immediately after delivery, the fundus palpated midway between symphysis pubis and umbilicus. At 1 hour, fundus is at or slightly below the umbilicus. Within 12 hours, the fundus rises to the level of umbilicus, 1.3 cm above the umbilicus. By 24 hours, it becomes 1 cm below the umbilicus. After this, the fundus descends approximately 1 cm or 1 finger breadth per day. By 14th day, fundus no more palpable abdominally. Subinvolution. If there is an arrest or retardation of the involution, the process by which puerperal uterus normally restores to its proportions, then we call it as a subinvolution. The cause may be retention of placental fragments, pelvic infections, accompanied by prolongation of lochial discharge and irregular or excessive uterine bleeding, and sometimes by profuse hemorrhage. Placental site involution. A complete extrusion of the placental site takes up to 6 weeks. Immediately after delivery, it is a palm size, that means 3 to 4 cm diameter by the end of 2nd week. Placental site normally consists of many thrombosed vessels within the hours of delivery, ultimately undergo organization of thrombosis. Placental site exfoliation as a consequence of slugging of infractal and necrotic superficial tissues followed by a reparative process. Cervix. Small tears or lacerations may present. Rapid healing takes place. By the end of first week, cervix will form and external is in 1 cm diameter. Vagina. The hymen permanently torn and heals with small irregular tags of tissue. Vaginal mucosa heals and rugae regained by 3 to 4 weeks. By 6 to 10 weeks necessary for the complete involution. During the postpartum period, vaginal mucosa becomes atrophic and vaginal wall do not regain the thickness until estrogen production by the ovaries are established. Perineum. The muscles of pelvic floor and thin greatly during the 2nd stage of labor. And childbirth, the perineum edematous and bruised. Episiotomy site will take 4 to 6 months to heal completely. The laceration of the perineum also can occur during delivery. The cardiovascular system. The most dramatic changes in the system can take 6 to 12 weeks to return pre-pregnant stage. Slight increase in cardiac output after the childbirth by the flow of the blood back to the heart from the uteroplacental circulation. And also decreased pressure from the gravid uterus and by mobilization of excess extracellular fluid into the vascular compartment. The cardiac output persists for 48 hours after childbirth and return to normal by 2 to 3 weeks of postpartum. Hematocrit and RBC production stops. The body loses extra plasma volume by diuresis. That means decrease in adrenal hormone aldosterone as it decreases the sodium retention and fluid excretion. Decrease in oxytocin also causes diuresis. And also diaphoresis also will be increased. Coagulation. And elevated levels of coagulation factors continues for several days after delivery as a protection from PPH, causing continued risk of thrombus formation It takes nearly 4 to 6 weeks before the hemostasis returns to the non-pregnant state. Blood values. Marked leukocytosis occurs after delivery. WBC count falls to normal by 6 days after birth. Neutrophils as response to inflammation. Pain and stress to protect against invading organisms. Hematocrit return to the normal limit within 4 to 6 weeks unless PPH occur. Dilated renal pelvis and ureters return to the pre-pregnant stage by 2 to 8 weeks after delivery. And also because of the autolysis, there will be increased urine production diuresis during the puerperium. Most women return to normal maturation by 3 months of postpartum. Careful attention to the postpartum and prompt catheterization for those who cannot void will prevent the most of the urinary problems. Broad and round ligaments of the abdomen will become much more and lax than the non-pregnant. Abdominal wall return back to normal, but it needs several weeks to be aided by the exercise. Ovarian function. Estrogen and progesterone level decrease rapidly after the placenta delivers. Estrogen reaches the follicular phase by 3 weeks after birth as long as the woman is not lactating. Ovulation may occur as early as 27 days after delivery. Average time for 7 to 75 days post-delivery and 190 days post-delivery if this is breastfeeding. Kidney and bladder function. Mild proteinuria is common for 1 to 2 days after delivery in 50% of postpartum women. Bladder tone returns between 5 to 7 days of postpartum. The stress incontinence is common during the first 6 weeks of postpartum. Hematuria immediately after vaginal birth indicative of bladder trauma. If hematuria occurs after the first 24 hours, it is an indicative of urinary tract infection. Respiratory function returns to normal by 6 to 8 weeks of postpartum. The basic metabolic rate increases for first 7 to 14 days secondary to mild anemia, lactation and psychological changes. The GI tone and mobility decrease in early postpartum causing constipation. Normal bowel function returns approximately 2 to 3 days postpartum. Liver function returns to normal approximately 10 to 14 days of postpartum. Gallbladder contractility increases normal, allowing expulsion of small gallstones. Digestions become active, so more hunger and thirsty. Constipation is a major problem because of the bowel tone and motility was sluggish for many days, restricted food and fluid intake during labor, and pain during defecation. Normal pattern of bowel elimination resumed by 8 to 14 days after postpartum. Weight loss. Uterine evacuation and normal blood loss for nearly 5 to 6 kg. Further decrease during diuresis is 2 to 3 kg. Factors for weight loss, weight gain during pregnancy, primiparity, early return to work outside home, smoking. That is not affected by breastfeeding, age and marital status. Musculoskeletal system hormone relaxing gradually decrease the ligaments and cartilage of the pelvis begin to return to the pre-pregnant stage. Generalized fatigue and weakness is common, decreased abdominal tone is common. Neurological system, discomfort and fatigue is present. Complaints of headache should require careful assessment. Frontal and bilateral headache are common and caused by fluid shift. Non-REM sleep is absent after birth and is increased during the next 2 weeks. REM sleep decreases as the non-REM sleep increases. Integumentary system. When the hormone level decreases, the skin gradually reverts back to the non-pregnant state. Loss of hair occurs as a normal response to hormonal changes. Stria lightens and melasma is usually gone by 6th week of postpartum. Hair loss can increase for 4 to 20 weeks and regrowth will occur. Endocrine system. After the expulsion of placenta, levels of placental hormones decline rapidly. HCG is present for 3 to 4 weeks. Thyroid levels normal by 4 to 6 weeks of postpartum. Glucose levels are low secondary to decreased human placental lactogen. With the loss of placenta, circulating levels of estrogen and progesterone decrease and levels of prolactin increases. Colostrum, a yellowish fluid that contains more minerals and protein but less sugar and fat than mature breast milk, have laxative effect secreted for first 1-2 days of postpartum. Mature milk secretion is present by 3rd postpartum day. Breast engorgement with milk, venous and lymphatic stasis and swollen, tense, tender breast tissue may occur 3 to 5 days of postpartum. Deep lemon yellow colored liquid secreted initially by the breast is called as colostrum. Contains more minerals and protein. Persists for 5 days. Gradual conversion to mature milk during the ensure in the 4 weeks. Endocrinology of lactation includes progesterone, estrogen, placental lactogen, prolactin, cortisol, insulin. Appears to act in concert, stimulate the growth and development of milk-secreting apparatus of the mammary gland. Prolactin is essential for lactation or the plasma of prolactin falls after delivery. Sucking triggers a rise in the prolactin. Milk ejection or letdown reflex, initiated especially by suckling, will stimulate neurohydrophysis to liberate oxytocin, contraction of myoepithelial cells in the alveoli and small milk duct, milk expression from the lactating breast. Immunological consequence of breastfeeding, predominant immunoglobulin in the milk is secreted IgA, contains IgA antibodies against E. coli. Breastfed infants are less prone to enteric infections, contain both T and B lymphocytes. Lactogenesis. It means the milk initiation which occurred during the later weeks of pregnancy. Physiology of lactation include 4-step preparation of the breast mammogenesis, synthesis and secretion of the breast alveoli is lactogenesis, ejection of milk is galactogenesis, and maintenance of lactation is galactopoiesis. Preparation of breast. Pregnancy associated with the remarkable growth of both ductal and lobular system. Synthesis and secretion of the breast alveoli, that is lactogenesis. Even though some secretory activity is evident during antepartum period, milk secretion actually starts on 3rd or 4th postpartum day. In spite of high prolactin level during pregnancy, milk secretion inhibited due to high circulating levels of estrogen and progesterone. Prolactin, insulin, and growth hormone and glucocorticoids are important hormones in this stage. Ejection of milk or galactogenesis. Oxytocin is the major galactokinetic hormone. Discharge of milk from the mammary gland depends not only suction exerted by the baby during suckling but also on contractile mechanisms which express the milk from alveoli into the ducts. During sucking, the conditioned reflexes set up, oxytocin is liberated from the posterior pituitary, produces contraction of myoepithelial cells of alveoli and ducts containing milk. This is the milk ejection or milk letdown reflex whereby milk is forced down into the ampulla of the lactiferous ducts where it from expressed by the mother or sucked out by the baby. Presence of infant or infant's cry can induce letdown reflex without sucking. Milk ejection reflex is inhibited by factors such as pain, anxiety, breast engorgement, or adverse psychic conditions like depression. The fourth one is maintenance of lactation. Prolactin appears to be the single most important galactopoietic hormone. For effective and continuous lactation, frequency of sucking is essential. Distension of alveoli by retained milk is due to failure of suckling. This causes decrease in the milk secretion by alveolar epithelium. Ductal and alveolar distension due to failure of milk transfer is a cause of lactation failure. A healthy mother will produce about 500 to 800 ml of milk per day to feed the baby. It requires 700 kilocalories per day for a mother, which must be made up from the diet or from her body store. For this purpose, a store of 5 kg fat during pregnancy is essential to make up any nutritional deficit during lactation. Lactation failure or inadequate breast milk production. It may be due to infrequent suckling or due to endogenous suppression of prolactin by ergot preparations, pyridoxine, diuretics, or retained placenta. Pain, anxiety, and insecurity may also be the hidden reasons. Drugs to improve the milk productions include galactogogues. Normally, metoclopramide or Peritoneum 10 mg TID increases the breast milk volume to 60 to 100% by increasing prolactin level. Dopamine antagonist Peritoneum has been also found to be effective by increasing prolactin level. Intranasal oxytocin contracts the myoepithelial cells and causes milk letdown. Lactation suppression. It may be need for the woman who cannot breastfeed for a personal or medical reasons. Methods commonly used are to stop breastfeeding, to avoid pumping or milk expression, to wear the breast support, ice packs to prevent engorgement, analgesics to relieve pain, and tight compression bandage is applied for 2 to 4 days. Medical methods of suppression with estrogen, androgen, or bromocriptine not advised because of the high complications. Initial assessment during the postpartum include vital signs, skin color, lactation and firmness of fundus, amount and color of lochia, perineum for edema, episiotomy, laceration, hematoma and for bleeding, presence and location of pain, IV fluid type, rate, etc., urinary output time and amount of last voided urine, legs for thromboembolism, assess for homocysteine. If the mother is Rh negative, give anti-D injection. In short, it is comes and bubblers. B means breast, U for uterus, B for bowel, B for bladder, L for lochia, E for episiotomy, R for emotional response and sign, S for homocysteine. Postpartum assessment. The first every 50 minutes for the first 1 hour, every 30 minutes for the second hour, every 4 hours for the first 24 hours, thereafter every 8 hours. Vital signs BP. If the BP is 140 by 90 of mercury or more, higher preeclampsia may be present. Pulse, bradycardia or tachycardia indicate anxiety, pain, dehydration or infections. Temperature up to 38 degrees Celsius is common in the first 24 hours. And pain. Fundus. Check the firmness of the fundus at regular interval. Consistency and location. Difficult to locate or bogey. Stimulate the uterine muscles to contract by gentle massaging the uterus. Breast size, contour, symmetry, engorgement, nipple cracked, redness, fissures or whether erect or inverted. Lochia we have already seen. Perineum, observe for radar. R for redness, edema, ecchymosis, discharge, approximation of the wound. Bladder elimination. Mother may not feel urge to void even if it is full. It can feel abdominally above the symphysis pubis. Frequent voiding less than 150 ml suggests urinary retention. Breast, lower extremity. Subsequent postpartum assessment. Check the firmness of the fundus at regular interval. Perform fundal massage if the uterus is not firm. Inspect for the perineum for regularly for frank bleeding, not the color, amount and order of lochia. Count the number of perineal pads that saturate in each 8 hours. Assess vital signs at least twice daily and more frequently if needed. Evaluate interaction and care skills of the mother and family with the infant. Assess the breast engorgement and condition of the nipples if breastfeeding. Inspect legs for signs of thromboembolism. Assess for homocysteine. Assess incisions for signs of infection and healing. Evaluate the episiotomy using acronym RADA. The mother is Rh negative, give anti-D injection. If the woman is not rubella immune, rubella vaccination and pregnancy should be postponed for 3 months. Early ablation, less frequent bladder complications and constipation, reduce frequency of epithelial venous thrombosis and pulmonary embolism. Care of vulva should instruct to cleanse the vulva from the anterior to posterior. Ice bag can be applied. Warm sitz bath can be applied up to 24 hours after delivery. Bladder function we have already seen. And during the first few days after vaginal delivery, uncomfortable way after pains, episiotomy, laceration, breast engorgement, aspirin or acetaminophen can be given. Abdominal wall relaxation exercise to restore the abdominal wall any time after the vaginal delivery, as soon as the abdominal soreness diminishes after the cesarean delivery. Diet. Now restrictions for the women who have been delivered vaginally 2 hours after normal vaginal delivery. Lactating women should be increased in calories and protein. Non-breastfeeding dietary requirement as for a non-pregnant woman. Immunizations we have already seen. Follow-up care. Normal vaginal and puerperium women can resume most activities by the time of discharge. Follow-up examination during third postpartum week has been proven quite satisfactory. Identify any abnormalities of the later puerperium. Initiate contraceptive practice. The management of normal puerperium include rest and ambulance, the hospital stay, diet, care of bladder, care of bowel, sleep, care of the vulva and episiotomy, care of the breast, asepsis and antiseptics and immunization. Postpartum warning signs are fever more than 38 degrees Celsius, false melochia, visual changes, calf muscle pain, swelling and pain over the episiotomy, shortness of breath, depression, increased respiratory rate, heart rate, and decreased BP are orthostatic signs which indicate bleeding, excessive vaginal bleeding. Bogey uterine fundus that does not become firm and remain firm with massage, decreased urine output. The nursing management during immediate puerperium, acute pain related to mechanical trauma and tissue trauma, knowledge deficit related to the breastfeeding, high risk for the infection related to the tissue trauma, decreased HB, prolonged rupture of membrane, high risk for injury related to abnormal blood profile, development of PIH, altered urinary elimination related to mechanical trauma, tissue edema, high risk for fluid volume deficit related to the reduced intake, inadequate replacement, constipation related to decreased muscle tone, effect of progesterone, mechanical trauma, ineffective individual coping related to childbearing and assuring role, the role of motherhood and parenting, sleep pattern disturbance related to and knowledge deficit related to self-care and newborn care. Thank you for listening. If you have any suggestions, corrections, modifications, please let me know.